of operating early in esotropia, because this is a very important, because child born with esotropia, the problem of course, amblyopia as well as binocularity. But I think what you said that after 2 years there is no binocularity, ऐसा नहीं है. Even if you operate, I mean 6 months to 12 months, the binocularity is good. But even after 2 years, 2 to 5 years, there is some binocularity. And most of these patients go into monofixation syndrome. That is, so they still have some binocularity. Yes. Doctor? Monofixation is not binocularity. That, yeah. But they have 800 seconds of arc binocularity. So, I agree.
You should operate before 2 years.
But his was that there was no binocularity.
Definitely suggests that you should be operating before 2, and now recently.
Yes.
Yeah.
6 months to 1 year is the
1
best,
year
best,
will be
best time.
Young children have their own surgical issues also
Yeah.
at the age of
Dr.
6 months, but by 1 year I think there is no point. So any time after 6 months.
Yeah.
And before 2 years.
Between 6 months and 1 year is the ideal time. Is the ideal time.
Now, Professor Shukla will be talking about IDS, natural history and management.
Well, good morning, everybody. We are sparse delegates, but very interested delegates, I suppose. So, intermittent divergent strabismus is another problem. Just like infantile esotropia, this is another problem. And I think for infantile esotropia, we have some standard procedures now, or standard theories now. But for intermittent divergent strabismus, you see, there is still a lot of dilemma. I'll just try to, see, intermittent divergent strabismus, or IDS, as is commonly known, is a common disorder of ocular motility. As there are so many forms of disorder, management is not only dubious but also controversial. Many ocular conditions are also connected with disorder, because there are many syndromes which are associated, which further confuse the management. Now, you see, the dilemma lies because you have to first understand the natural history of strabismus, divergent strabismus. So, because there are a lot of protocols associated with it, so until and unless you don't understand the natural history of strabismus, you will not be able to go for the treatment. Now, to begin with, the condition is usually innocuous. Very gradually it's progressing. Many times the parents or the teachers would not even notice it until unless it is far progressed, and is hardly noticed until some symptoms appear. This is one thing more. Patients may complain of ocular asthenopia sometimes also, and may or may not come for consultation. If they develop refractive errors, spectacles are given, but ocular motility is seldom checked or assessed actually, as all women is placed on the refractive error, and most of the doctors who are practicing strabismus, they say, "Aap chashma laga lijiye, aapka ye bhengapan theek ho jayega." The other problem is that don't worry, the child is very small, his vision is good, 6 by 6, bada hoga, apne aap theek ho jayega. This is one of the very common this thing. Now, as woman is probably refractive error, when problems of asthenopia aggravate and motility is checked and exophoria is detected, that's the best thing to start with that. Now, if left untreated, may develop into an intermittent or a constant manifest exotropia. A lot of symptoms depend upon the type and length of near work undertaken. This depends on that. Now, we are going through the natural history now, that what happens in a chronological order. With increase in exophoria or intermittent exotropia, the patient begins to feel the heat of the disorder, and intermittent diplopia, headaches, blurring of vision start. Now this is the time when they actually come for this. The patient himself begins to feel subjectively the sudden movement of eyes and the effort to bring it back to the primary position. This is what the patient starts feeling when there is an obvious intermittent exotropia. And it brings us back because of the motor fusion, so they start subjectively feeling this now. Onlookers start commenting. Now this is the time that things have started taking place, and serious consultation is now sought. Now, so what happens? So when the patient comes for consultation, Now, when the patient comes for consultation, the approach to management depends upon the following disorders. The degree of phoria. This is one important thing, the degree of phoria. So how much exophoria is elicited? Uska bhi ek grade hai कि when you should you be serious for it, when you should give some orthoptic exercises, or you just leave it because there's no symptoms. Then the number of waking hours the eye goes into manifest tropia. Time and type of occasion when the eye drifts. Annoying symptoms when the eye drifts. Are there any symptoms when the eye drifts? As I told you before, the patient start feeling intermittent diplopia, blurring, headaches, asthenopic symptoms and all that. Uniocular or a binocular problem. Is it corrected with spectacles? Is the patient conscious of the problem? That is one of the very important criteria for that. Many times, you see, the patient does not have problems. There are so many people who have intermediate, even up to old age, adult age. They are not bothered because it does not bother them. So if it is only a cosmetic blemish, or is it really causing some symptoms and problems to the patient? Is the patient on any medications? Please ask this question, which is very important. People on psychotropic drugs, on sedatives, for anti-epileptic drugs, they all go into intermittent exophorias and tropias. Always ask if the child is taking any medication. This is very important. Now, I'll show you some examples where the problem arises. Now, this is a girl, 13, 14 years of age. This is a simple test we do, cover uncover test, nothing is elicited. But the patient is having problem. The patient has come for some problem. The vision is 6 by 6. Now see, when I do an alternate cover test, there is a small movement of exophoria, small movement of exophoria. Now, another child. The eye is orthotropic. Now see, just a little amount of cover test causes the deviation. Otherwise he is orthotropic, orthotropic I mean. And when I tell the patient to look constantly, even see the eye drifts out. Eye drifts out and gradually it comes back to the position. It drifts out. Another child. Sorry. Anyway, we go to the another which is not working. Another girl, 6 to 7 years of girl. Now I tell the patient to look constantly and gradually the eye drifts outside. I have done nothing. Not even cover test I have done. It's no cover and cover test. But even just telling the patient to look out, gradually the eye drifts outside. The fixation is good. There is no problem. But even when I tell the patient, I have not done anything, no cover and cover, but even when I tell the patient to look straight, the eye drifts. So this is a very common problem that when the patient is not very conscious, or is looking at TV, or is, what all we have, those, daydreaming and all those sort of things, or even when the patient looks at the board, the teacher complains. This patient had come because the teacher has complained कि जब ये दूर का board पे देखती इसकी एक आंख घूम जाती है ऐसा लगता है. So the child is not knowing, the child does not know about it. But when the child looks at the board in the class, the eye gradually drifts outside. So these are the problems, multiple different problems the patient would come to you. Now, one of the very important thing is now congenital exotropia or congenital exodeviation. Now, this is the child which came to me with a manifest large angle exotropia. And I asked the patient, "Sab, ये तो जब से पैदा हुआ तब से ही है." This is a very common, statement, but you must confirm it because congenital exotropias have a very bad prognosis of binocular vision. So you must always get, I always, as a rule, tell the patients to get the photographs of the infancy, first year, birthday, second, whatever. It is mandatory that you must ask for photographs from the patient. Now see this child, just about 6 months, 5 to 6 months, and is a large angle esotropia, right, a uniocular, unilateral large angle esotropia, right from birth. So now we have to look into this for many reasons, because first thing is you must do a fundus examination, because congenital or infantile exotropias have a problem in the fundus. So you must always look for patient को आप under GA पूरा examine करिए ठीक से. Okay? So this is the patient who comes now with the Spillman. When you see the occluder, the patient is going to that. So now what, when you see all these types of patient, what do you think to be done for these patients? Now the poles of management are exophoria under 15 PD without symptoms can be left alone. But to be kept under observation, any associated refractive error must be corrected. Exophoria above 15 PD should be given orthoptic exercises. Any phoria with symptoms should be treated with orthoptic exercises. Intermittent tropia should be evaluated for refractive error and continued with orthoptic exercises. Should be watched carefully for increase in tropia or symptoms, and patients' concurrence for surgery must be taken. Because these patients, especially parents, do not agree for surgery because they say the बच्चे को तो अच्छा दिखता है, and even if you see the vision, it is 6/6. So every visit should have measurement of tropia, vision, and stereo acuity. This is very important. Decrease in stereo acuity is an indication for surgery. Small alternating tropias can be kept under observation. If tropia becomes uniocular or constant, surgery is indicated. Patient's concurrence for surgery is of paramount importance. In infantile tropia, fundus examination under GA is mandatory. Thank you very much.